And then are there resources, what resources do you recommend to patients when, let's say, their insurance is not necessarily cooperating or they reach like a price ceiling or something like that?
Well, we have patient advocacy groups. We have coupons or copay from pharmaceutical companies to help their patients. I can tell you, for example, when we start a treatment like a asciminib, Novartis providing free drugs at the beginning. So there's ways to get things done. But in a setting of generics being available, it still remains hard to justify new drugs. When you have a drug like imatinib costing $400 per year, it's hard to go for other drugs.
Mm. Some of your recent work reported successful treatment for remission after ponatinib and discontinuation in pretreated CML patients. What criteria should guide clinicians in considering TKI discontinuation, and maybe what are the risks of relapse in these scenarios?
Well, let me differentiate here. When you consider stopping TKI in a second line, third line, I think the success is mainly seen in patients who are intolerant to first line of drug. Means if somebody had resistance to first line drug and getting a second line, I'd be reluctant to consider stopping therapy. It's more the TFR is more successful when you have an intolerance. No, that being said, whether in the front line or relapse or the second line and you want to consider treatment for remission, you must aim for a deep molecular remission sustained for a bit. Uh, I know the guidelines recommend 2 or 3 years. In our experience, we've shown that if you have 5 years of deep response and you stop, your success rate goes up to 80% and even higher. Something was around 40 to 50% if you do 3 years. So the longer you stay, the longer your response is, higher is the likelihood of stopping and remaining free of the disease.
Mm. And are there any other key predictors of successful remission off?
The only one today that seems to be predicting is the duration of deep molecular remission,
Mhm.
not the drug, not anything else.
Yeah. So your JAMA Oncology review highlights the rapid evolution of ALL management with combinations of TKIs and immunotherapy replacing prolonged chemotherapy. What are the practical implications for frontline therapy selection?
You know, stopping therapy is very important because it's important for the patients from the compliance, adverse event and outcome, and financial. I mean, copay for lifetime is something can be a big burden. However, we have not been successful yet to identify the best strategy to stop treatment, except giving the drug for as long as possible and be able to induce a deep response and stop after 5 years. But what we aim to do is maybe if we combine the TKI with other drugs, then we don't have to wait too long to stop.
Mhm.
And then when we stop, the success rate is higher. And we use rationale from the lab medicine, such as laboratories data, in vitro data, for example, combination of BCL2 inhibitor and TKI, HMA and TKI. But in all honesty, today we have not been successful. We are trying. We need longer follow up, and we have not seen the combination can improve the response can improve the depth of the response, rate of response, and the TFR as such. There's some data on JAK2 inhibitors, but still the data is not solid enough.
Mhm. Do you have any ideas on how you see this evolving in the next 2 years, in the next few years?
Well, I want to see a drug or a combination inducing a higher rate of sustained molecular remission. I think if you can meet this endpoint, then you can successfully stop the treatment and win. This is what we're doing right now, and still we're on our way.
Mhm.